afternoon, everyone, and welcome to the Metrobank Foundation Fellowship in Public Service, or FPS Conversations. I am Crystal Tagpor-Patino, Program Officer of the Excellence Awards Unit of Metrobank Foundation, and I will be your host and co-moderator for today. Before we start, may I request that you check the link of the feedback form shown on your screen. Or if not now, it will be shown later. Because your opinion, of course, matters to us. We want to know what you think of our event. So please do answer the form afterwards. We will be providing certificates of participation to those who answered the feedback form. Also, as you listen to the 3 lectures later, we encourage you to type your questions in the Q&A box for the Zoom participants and in the comments box for our FB Live viewers. By the way, we are streaming live at the Manila Doctors Hospital Facebook page along with Manila Titana College's Facebook page. So hello to all of our FB Live viewers. Let us now watch this video for further reminders about the event, as well as the background of what the Metrobank Foundation Outstanding Filipinos Award is all about.
History offers the best examples of outstanding service. Men and women who remind us of patriotism, courage, integrity, and social responsibility. These are the same qualities that we like to honor among today's teachers, soldiers, and police officers. They are a testament to the culture of excellence that Metrobank Group founder Dr. George S.K.T. has always envisioned for our country. He believes that putting a premium on achievement sets a high standard in service crucial to nation building. The Metrobank Foundation Outstanding Filipinos is an awards program which has recognized hundreds of teachers, soldiers, and police officers for their exceptional work in their chosen field. The award values the abilities and potentials of people to excel and bring about change in the country. The task of nation building has become challenging. Outstanding Filipinos are expected to render service above and beyond the call of duty. To be outstanding means to go beyond excellence, to transform lives, make a difference, inspire others. The Metrobank Foundation Outstanding Filipinos, now the country's most coveted professional service award. A fitting tribute to selflessness, integrity, courage, and social responsibility. Metrobank Foundation Outstanding Filipinos, beyond excellence.
So welcome once again to this Fellowship in Public Service Conversations with 3 of our Metrobank Foundation Outstanding Filipino Teacher Awardees with their talk entitled Medical Breakthroughs for a Better Normal. So let me just acknowledge our guests and speakers who are with us today, along with our viewers. So Dr. Eva Cutiongco-de, Dr. Thiele Isip-Tan, Dr. Maria Minerva Calimag, Mr. Aniceto Sobrepeña, the President of Metrobank Foundation, along with Mr. Nicanor Torres Jr., our Executive Director. Hello also to our partners from MDH, or Manila Doctors Hospital, and Manila Titana Colleges. Dr. Bernadette Hugar Manlapat is here, along with Dr. Mario Joselito Cuco. So hello everyone, and I hope you enjoy and learn a lot from our activity and our webinar this afternoon, especially with our speakers. So to start the program, may I call on the Executive Director of the Metrobank Foundation, Mr. Nicanor Torres Jr., to lead us in prayer. We will have the singing of the Philippine National Anthem afterwards. Sir Nick, are you there?
Okay,
Please
all
go
right.
ahead, sir.
Okay, do you hear me now? Hello?
We can hear you, Sir Nick. Please go ahead.
Do you hear me now?
Yes, Sir Nick,
O-
we can hear
Okay,
you. You may
all
start.
right. Okay. Heavenly Father, we thank you for gathering all of us today for the Metrobank Foundation Fellowship in Public Service Conversation event. Thank you for this opportunity that you have given our outstanding Filipino awardees to share and impart their knowledge and best practices to the Filipino people. We acknowledge that without your blessings, all this would not be possible. May you bestow your guidance and blessings on everyone present, that each of us may be able to fulfill our respective roles and make the best of this experience. Coinciding with today's theme of a better future, we thank you for the gift of knowledge, wisdom, and understanding that we are about to learn through our speakers, who are all highly regarded figures in the medical community. May we learn from their expertise as they discuss the future of medical education in our country. We thank them for their service and generosity, for spending their time with us this afternoon. We rejoice in the hard work that they have put in for today's conversation. We live up the success of this event to you, and we humbly seek your guidance in all our endeavors. And may you continue to bless us, and most especially those who need your help and mercy the most. In Jesus' name, amen.
Bayang pag-iliw, perlas ng sinamanan, alam ng puso, sa isip ko'y buhay. Lupang hinirang, duyot na ng agiting, saan lulupi, di ka pagsisihin, sa dagat at bundok, sa simulan, sa langit bumabang, may dilagang tulan, awit sa lanay, minamahal, ang isa ng watawat mo'y tagumpay na nagdidikit, ang bituin at araw niya kailan pa ba'y di magdidilim, lupa ng araw na lalanin ang kita, buhay ay langit sa piling ko, ang ligaya ng pagkay makakit, ang mamatay ng dahil ngayon.
Now to formally open today's Metrobank Foundation Fellowship in Public Service Conversations, may I request the President of the Metrobank Foundation, Mr. Aniceto Sobrepeña, to deliver his welcome remarks.
Good afternoon. It is with much pleasure that I welcome you all to the first in a series of Metrobank Foundation Fellowship in Public Service Conversations for 2022. The long-drawn COVID-19 pandemic has highlighted the critical role of doctors, our modern-day heroes, as well as the urgency to shape the next generation of physicians who will address the heightened level of healthcare demands of our countrymen. We are here today because we look for a better future in the health profession. With the pandemic undoubtedly disrupting the well-established traditional structure of medical education and professional development, the FPS Conversations is one of the avenues for learning continuity. Today, we are proud to present to you three distinguished resource persons who will talk about digital transformation, precision medicine, saktong lunas para sa saktong Pinoy, and thirdly, population pharmacogenomics and precision public health. As we move from conventional to digital transformation, and as our experts share their knowledge acquired from years of experience and study, it is our hope that these conversations will trigger more discourse and action for building resilience against future risks and threats. Today, we are likewise pleased to confer to our distinguished awardees the title Metrobank Foundation Fellows in Public Service. Through this fellowship, it is our fervent vision to harness the wealth of experience and expertise of our awardees to benefit key groups and the society in general. Their lives and accomplishments also serve to inspire others to replicate or even surpass these outstanding achievements. This fellowship in public service accords both honor and responsibility to the awardee. Honor as opportunities arise to extend their influence and widen their leadership, and responsibility as they are continuously challenged to pursue more meaningful contributions to our society. To date, the program has successfully implemented 15 joint and individual lectures and 2 roundtable discussions. And we have gathered more than 2,000 participants composed of teachers, professors, students, soldiers, police officers, local chief executives, key government officials from various parts of the country. We hope to encourage dialogue across sectors and bring innovations and advocacies of exemplary individuals to further develop future policies, strategies, systems, and even the curriculum. At this point, let me thank Dr. Thiele Isip-Tan, Dr. Eva Maria Cutiongco-de and Dr. Maria Minerva Calimag for your dedication to service beyond excellence. Congratulations and mabuhay.
Thank you, Mr. Chico Sobrepeña, for that warm welcome for all of the viewers here this afternoon. So let us now move on to the conferment of the fellows in public service. So to start, let us watch this vignette about Dr. Eva Cutiongco-de.
It's a good inspiration for other people that they can try, imbibing their children, especially the mother, the teachers, the same love that they have for something, and they will succeed if they will really try very hard.
Ang pagiging guro ko ay nakikita sa pagtuturo ko sa medical students. Ang genetics ay hindi kilalang spesyalidad. And it meets the needs of patients that are not met by any other specialty in medicine. So in fact, hindi lang sa classroom ang aking pagtuturo. Kasama sa pagtuturo ko sa ospital at pati na rin sa komunidad, at isang malaking parte ng buhay ko, dahil ako rin ay isang researcher, ay ang pagtuturo ko how to do research in genomics. Tingin ko, ang isang magaling na guro ay dapat unang-una ay magaling din mag-research. Sapagkat hindi pwedeng ang aming tinuturo ay laos na. Ang dapat tinuturo namin ay kung ano ang ngayon at kung ano ang haharapin namin na mga hamon bukas, dahil hindi naman pwedeng maiwan ang Pilipinas.
At this juncture, we shall now confer the Metrobank Foundation Fellow in Public Service title to Dr. Eva Cutiongco-de. Allow me to read the citation. Metrobank Foundation Fellow in Public Service is being conferred to Eva Maria Cutiongco-de, MB, Professor 12 of the University of the Philippines, Manila. As 2019 Metrobank Foundation Outstanding Filipino Awardee, she is recognized for being the prime mover in advancing genomic medicine and education in the Philippines. Together with a colleague, she established the first and only clinical genetics fellowship program in the country, equipping clinicians and researchers about the role of genetics in health and disease. Her extraordinary work in understanding X-linked dystonia Parkinsonism, or XDP, ensured that genetic education, testing, and counseling is integrated in the clinical care of patients with birth defects and other genetic conditions. Given this 23rd day of February 2022 at the Metrobank Plaza, Senator Hill Puyat, Makati City. Congratulations, Doc Eva. You are now a Metrobank Foundation Fellow in Public Service.
Thank you very much to Metrobank Foundation, and thank you, Ma'am Crystal and Sir Chito. Maraming salamat po, and Sir Nick, and sa lahat po ng nasa Metrobank Foundation. Sobra pong malaki pa sa salamat at napakalaki po itong karangalan. Thank you po.
Thank you, Dr. Eva, and congratulations once again. Next, we have Dr. Thiele Isip-Tan. Let us watch her video.
I often get asked, why didn't you leave? And I said, because I wanted to give back to the Philippines, because I want to serve my country. We know that many of our graduates leave for abroad to serve elsewhere. And then when they're there, they sort of lose the connection. One of the things that the UP College of Medicine is doing is trying to get them into the college, especially now because it's more online. So we can ask them, for example, to give presentations to our students, and then they remember that there is back home, there is a need for our graduates to stay so that we can serve the Philippines, especially now in the pandemic. I believe that academics should not be in their ivory towers. We need to be where the people are, and right now there are those who are online, and that's why we need to also influence them in those spheres.
Okay, let me read the citation for Dr. Iris. Hello, Dr. Iris. Congratulations. You are now Metrobank Foundation Fellow in Public Service. So Metrobank Foundation confers the Metrobank Foundation Fellow in Public Service to Iris Thiele Isip-Tan, MD, MSc, Professor 10, College of Medicine, University of the Philippines, Manila. As 2021 Metrobank Foundation Outstanding Filipino Awardee, she is recognized for pioneering the use of team-based flipped and blended learning at the UP Manila College of Medicine. She spearheaded the college-wide use of a learning management system even before the pandemic, easing the transition to remote teaching and learning in the new normal. Again, given this 23rd day of February 2022 at the Metrobank Plaza, Senator Hill Puyat, Makati City. So congratulations, Ma'am Iris. Do you have words?
Thank you very much. And I would like to thank the Metrobank Foundation and everyone in it, Sir Chito, Sir Nick, Ma'am Crystal, everyone on your team. I heard what Sir Chito said, so I accept not only the honor, but the responsibility. Thank you for the opportunity.
Thank you very much, Doc Iris. And again, congratulations. Very excited to hear you later. So finally, we have Dr. Maria Minerva Calimag, and let us watch her video.
I'm able to shape minds. I'm able to speak my mind regarding many issues related to the profession of medicine. My major accomplishment that I will consider my best legacy is having reared 8 children, 7 of whom are already physicians. That number 8 is already in third year medicine. Legacy po yan, lahat po sila ay frontliners. I was their first teacher, of course. We have been promoting nationalism both in the workplace and in all the national organizations that I have led. Especially the love for language. I've actually started now an advocacy also towards the promotion of the use of the Filipino language in medicine.
Hi, Doc Irvi. Congratulations. Let me just read your citation. Metrobank Foundation, again, confers the Metrobank Foundation Fellow in Public Service to Maria Minerva Calimag, MD, MSc, PhD, Professor 5, College of Medicine, University of Santo Tomas. As 2021 Metrobank Foundation Outstanding Filipino Awardee, she is recognized for her proactive advancement of e-learning in medical education. She conceptualized, initiated, and co-developed cloud-based online programs such as the OWL at PMA for continuing professional development of healthcare practitioners. She utilized digital media to advocate pharmacovigilance on drug safety and anti-drug counterfeiting initiatives. Given this 23rd day of February 2022 at the Metrobank Plaza, Senator Hill Puyat, Makati City. Congratulations, Dr. Irvi. Do you have any words?
Thank you so much to the Metrobank Foundation, to Sir Chito Sobrepeña, for this award, the Fellowship in Public Service. Maraming salamat po.
So congratulations once again to our new fellows in public service. And so, without further ado, may I now call on our first speaker, Dr. Iris Thiele Isip-Tan, 2021 Metrobank Foundation Outstanding Filipino Awardee, currently Professor of UP College of Medicine, Director of UP Manila Interactive Learning Center at the UP Medical Informatics Unit, for her talk entitled Digital Transformation, the Future of Medicine. Doc Iris.
Thank you. So good afternoon, everyone. I'm very happy to be here today. Let me just put up my slides. Okay. So the expansion of telemedicine brought about by the COVID-19 pandemic has changed the healthcare landscape. The digital transformation of medicine through big data, virtual reality, wearable sensors, and artificial intelligence is highly anticipated. But how these technologies can keep the practice of medicine person-centric and inclusive remains challenging. I would like to thank the Metrobank Foundation for this opportunity to talk about digital transformation, the future of medicine, for this fellowship in public service webinar. I agree with Dr. Mesco's view that digital health will require a cultural transformation. When disruptive technologies make data accessible to both caregivers and patients, our hope is that this will lead to shared decision-making and the democratization of care, moving away from the patriarchal, doctor-centric model. Let me walk you through the developments in big data analytics, artificial intelligence, wearables, and virtual reality, and how can these tech developments keep the practice of medicine person-centric and inclusive? Let's start with big data. Big data is big, with healthcare data volume defined in zettabytes. 1 zettabyte is 1 billion terabytes. So such data is generated in real time and collected at varying speeds in both structured and unstructured formats. Veracity is a challenge with inaccurate, missing, and inconsistent data. To derive valuable insights useful for decision makers, which data for what purpose needs to be identified. Data is the new oil. So an aggregated data set will possess more energy than an individual data set. Health data also has a lifespan where its value decreases as it becomes stale. So Swan categorized big data streams in healthcare into 3. Traditional data obtained from electronic medical records, medication history, and lab reports, which assist in delivering better outcomes. We also have omics data, which drives precision medicine, and data from the quantified self, from social media, wearables, and sensors, which provide information about behavior and lifestyle. So for medicine to benefit from big data analytics, governance is necessary. And the Universal Healthcare Act mandates the creation of a national health data repository under the Department of Health and PhilHealth. This requires that all entities handling data share information, and they can only do so if they have functioning and interoperable information systems. Security measures are essential to safeguard the data and maintain the public's trust. Health professionals will need training to extract meaningful insights and properly interpret reports. And to store the voluminous health data, cloud is the way to go. Our very own DICT has a cloud-first policy for government services. So what makes big data analytics different? Traditional analytics track care quality and outcomes in retrospective view by using deductive reasoning. In contrast, big data analytics uses inductive reasoning for prospective analysis of data. So possible questions that big data analytics can answer include: how do healthcare costs vary geographically? What treatment options seem most effective for various diseases? Why do some healthcare providers deliver better health outcomes? And there are several ways to actually analyze big data, and they are listed on the slide. The most widely used in healthcare is natural language processing. Natural language processing is a field of artificial intelligence that makes human language intelligible to machines. It combines the power of linguistics and computer science to analyze and extract meaning from text. So in this recent work, we used natural language processing, specifically by term topic modeling, to identify topic clusters in a corpus of 12,631 COVID-19 tweets geolocated to the NCR in the first months of the pandemic in 2020. We combined natural language processing with qualitative analysis to identify tweets with COVID-19 misinformation. We had to combine approaches as NLP was limited by code switching in our dataset. Tweets were not only in English, but also in Filipino or a combination of both languages, often containing colloquial terms as well due to the character limits. So this is something we're continuing to work on. Next is artificial intelligence or AI. The term was coined by Stanford professor John McCarthy in 1955. He defined this as the science and engineering of making intelligent machines. With AI, we can expect these machines to perform cognitive functions as human minds do, such as learn, reason, solve problems, or make decisions. And this, of course, raises ethical questions. If a patient dies due to an AI-based decision or recommendation, who is liable? Or in a reverse example, if a clinician does not follow the AI's recommendation and the patient dies, who is liable? So reminiscent of Isaac Asimov's 3 laws of robotics, the first of which states that a robot may not injure a human being or through inaction allow a human to come to harm, AI should follow the principles of beneficence and non-maleficence. While we may think that machines are neutral, able to treat every patient similarly, adhering to the principle of justice, the training sets by which machines learn can be subject to both gender and racial bias. For example, AI algorithms in dermatology can fail to identify lesions in the dark-skinned when training sets only contained light-skinned examples. So AI may also pose a threat to autonomy if it can process information faster or better than a human physician. Or should it? So Eric Topol has said the pinnacle of AI is being fully autonomous. But I don't think that will happen in medicine. AI will always need human backup. And in his book, Deep Medicine, the subtitle reads, How AI Can Make Healthcare Human Again. So how can that happen? By taking over repetitive and mundane tasks, AI can provide an avenue to make medical care more patient-centered by freeing the clinician's time to engage with the patients. Can AI unload clinicians from what has been termed as desktop medicine, where a considerable amount of time is spent on a computer, documenting progress notes, sending emails, writing prescriptions, and answering teleconsultations? Now, in addition to beneficence, non-maleficence, autonomy, and justice, explicability has been added as a 5th principle. We need to guard against the AI algorithm becoming a black box to humans, where we only see the output but do not understand how the output was derived. Humans need to understand and hold to account the decision-making processes of AI. So studies in AI in clinical practice have evaluated the following. First, performance. Was the AI application accurate, sensitive, or specific? Did it outperform the clinician? Second, clinician outcomes. Did it improve decision-making, workflow, and efficiency? How did clinicians perceive and accept these AI applications? Third, did AI improve patient outcomes, such as length of hospital stay, in-hospital mortality, ICU transfer, or readmission? And in this systematic review, only one study evaluated cost-effectiveness. So the systematic review found a research practice gap. Most of the research were proof of concept studies on AI algorithm development and validation using retrospective clinical data sets. And so the call to action here is for the healthcare AI research community to work closely with healthcare professionals and institutions to demonstrate AI in real-life clinical settings using rigorous research methods. Recently, I was very fortunate to join the multidisciplinary mental health PH team, where we had computer scientists, user interface engineers, psychologists, and mental health advocates to create Kapwa. Kapwa is the first Filipino mental health chatbot on Twitter. You can chat with Kapwa by sending a direct message to @KapwaMH on Twitter. We need similar opportunities for collaboration to advance the use of AI in healthcare. Next, let's take a look at wearable technology. The wearables can be worn as accessories, embedded in clothing, implanted in the body, or even tattooed on your skin. Wearables support the 4P medical model: preventive, predictive, personalized, and participatory medicine. Wearables can help its wearer make healthier choices to prevent disease, provide data to support proactive care, generate personalized insights to health data such as the number of steps taken, calories, even number of hours of sleep, allowing the patient to fully participate in self-care. So the 4 application areas for wearables in healthcare include the following: health and safety monitoring, where wearables can monitor walking speed, respiratory and heart rates, as well as oxygenation. Chronic disease management for cardiovascular disease, diabetes, or hypertension. Disease diagnosis and treatment, such as a wearable which can detect sleep apnea, or a wearable defibrillator for cardiac arrhythmia. And finally, for sports or neurologic rehabilitation, or to aid persons with disabilities in vision or hearing. So sensor technology in wearables collect multiple data points in a steady stream, and so oversight must be strengthened to protect the privacy and security of personal data. Because of the possibility of misdiagnosis or missed diagnosis due to faulty data or false alarms from these wearables, some form of legal regulation should establish industry standards towards a unified data classification and evaluation. At the previous #HealthXPH tweet chat I moderated, please do join us on Saturday nights, I asked, do physicians trust wearable data? Are there industry standards to ensure that these wearables are accurate? I remember someone shaking a pedometer, not really walking, but in order to simulate the steps. So the quest for low-power, high-performance batteries and high processing efficiency medical chips can only further advance the technology of wearables. As you can see, our phones are even getting thinner and lighter. This will speed up information processing and improve user experience. So wearables can also drive connected healthcare as part of the Internet of Things, combining cloud computing and artificial intelligence to develop a complete medical ecosystem to become more integrated in people's daily lives. Lastly, let's discuss virtual reality. So in contrast to augmented reality, where the physical environment is augmented by a sensory layer like graphics, virtual reality or VR environments are fully computer generated without a direct connection to the physical space. The VR environment is a low-stakes environment where it's possible to assess skills, for example, in neurosurgery. Metrics will include distance to target when implanting devices, surgery completion time, kinematics or surgical tool movement metrics, blood loss, and the volume and extent of resection. So the challenge in VR environments is to recreate the physical world while maintaining face validity, which is the extent of realism of the simulation to the actual task, and also maintain construct validity is the degree to which the results of the test reflect the subject tested. So can the VR environment accurately predict surgeon performance? So to date, haptic feedback or the feel when a surgical tool comes into contact with tissue. For example, if you're in VR and you're using a scalpel to slice the skin, the feel of that and the realism of tools are still rated poorly in VR environments. We're not there yet. Now, VR simulations have also been used in nursing education for procedural skills to improve technical knowledge and proficiency, for emergency response training to improve confidence, in soft skills training for empathy and psychomotor skills training. As in neurosurgery, haptic devices need improvement when teaching psychomotor skills such as auscultating organs, endotracheal suctioning, or inserting a Foley catheter. So in summary, for digital transformation to keep the practice of medicine person-centric and inclusive, we must balance the value of big data analytics with the risks of data breach. We must follow ethical principles in the development of artificial intelligence, establish industry standards to maximize the benefits of wearables, and include haptic devices and social interaction when designing virtual reality situations or simulations in health professions education. Thank you very much.
Wow, thank you for that, Doc Iris. There really are a lot of things that I'm very excited about. No, I thought we have been there are already a lot of advancements in the field of medicine, but still there's a long way to go. I'm very excited with at Kapwa MH, and then the simulations and the virtual reality. You have been talking about this also during your during your interview in the final judging. So very excited about that. Now, may I call on our may I call on Dr. Bernadette Hogar Manlapat, Head of the Quality, Safety, and Risk Management Office of Manila Doctors Hospital, because she will be facilitating the open forums this afternoon. Dr. Dindi.
Hello, Iris. Hello.
Hello.
Iris. Yeah, thank you for that informative lecture. May we request everyone to revisit your notes and the questions you have in mind for clarification and Dr. Iris sharing with us. There is a question here, Dr. Iris. The Filipinos are known globally for our healing touch and sought after for this trait. Clinicians from other countries visit and train the Philippines to learn the healing culture. With the digital transformation, how may the Filipino clinicians retain the healing touch culture?
So that's a very good question, and many people are worried about that, how digital will actually affect our interactions with our patients. When we tried to make the telemedicine guidance documents, for example, in 2020, one of the things we had put there is teaching website manner. So it's a different thing now to do telemedicine, and we really have to put that in the curriculum, all about website manners. So for example, we have to teach our students, how do we express empathy now when we are not able to touch our patients because they're on a screen? So do we do it non-verbally, meaning, something like leaning forward to signify that you are listening, or using gestures, or even verbally expressing empathy, which we might not have been used to doing because we would just tap them on the shoulder or hold their hand or hand them a tissue. But now we have to be very verbal because that's all we can do. So we will have to say things like, I understand how you feel, tell me more, etc. And then I was very happy to have been part of the Kapwa team because one of the things we looked at was, how do we make Kapwa Filipino? So it's a chatbot. So it's really very simple. It's still menu-based. You have to choose what you want to tell the chatbot. Like for example, nalulungkot ako, kailangan ko ng kausap, ganyan. And then we have options like, mag-sample ka ng joke, Kapwa. And then Kapwa will tell a joke. So these are things that I'm not sure I can find in chatbots elsewhere, but definitely the humor that we try to put in there is very Filipino. So it's all about making sure that we don't lose those human interactions, even if you're interacting with the computer.
Thank you, Dr. Iris, for that answer. There's another question for digital transformation. Are we there yet?
So Okay, so just last week, I was talking to a group of doctors to the barrios, and we were talking about telemedicine. And the group that I had who come from, for example, Zamboanga and Barm, Sulu, Tawi-Tawi, they were saying we're still a long way from having electronic health records, for example. But the thing is, there are steps that we need to take to make sure that the transition from paper charts to electronic medical records will be smoother. So, for example, the World Health Organization recommends that patients have a master patient index, meaning each patient should be assigned a unique number to identify them. But if you've gone to a local health center or a regional health unit, what we usually have are family envelopes. So there's an envelope, and then the record of the mother, the father, and the children will be in there, and there's no master patient index. So I was telling them there are little steps you can do. You may not have the Wi-Fi, the laptops, and the electronic health record right now, but when it does come to you, you will now be ready because you've made the necessary preparation. So I think that's true for everything else that I've looked at. For example, we do have wearables. I have patients who bring to me their pedometer and tell me I made so-and-so number of steps, or they show me the glucometer and the data there. But the thing is, we need to progress also and see what can we do with this data. I think asking those questions is very vital. I would like to say that we do also have a Master of Science in Health Informatics at the University of the Philippines, Manila, and I am the program director for that master's program. So if you have people interested for this field, please do send them to us.
I think a lot of our participants are looking forward for that because we have to move forward to that direction, and we really are getting there. Dr. Iris, thank you. I think we will have another open forum after all the lectures. We'll thank you, Dr. Iris, for answering those questions. I think we have to go back to Crystal. Crystal, back to you. Thank you.
Thank you, Dr. Dindy, and thank you, Dr. Iris. We also encourage our viewers to, just like what Dr. Dindy said, please type your comments or questions in the Q&A box for Zoom. And for the FB Live viewers, type your questions in the comments box. There will be a lot of open forums this afternoon after each lecture, and even a longer one after the 3 lectures are done. So please don't be shy and type in your questions and comments. Now, moving on to the next, we will now proceed with Dr. Eva Maria Cutiongco-de 2019 Metrobank Foundation Outstanding Filipino Awardee. She is a research professor at the National Institutes of Health at the UP Manila, a clinical professor at the College of Medicine, again in UP Manila. She's also the executive director of National Institutes of Health and director of health program at the Philippine Genome Center. She will be delivering her presentation with the title A Vision of Precision Medicine for Filipinos, Saktong Lunas para sa Saktong Pinoy. Doc Eva.
Hello, good afternoon. I'll just pull out my slides. Good afternoon po ulit. Magandang hapon. Thank you to the Metrobank Foundation for the opportunity to share our work through this fellowship in public service. We hope this research work can be translated soon to contribute to a better normal for our country. This is the outline of my presentation. I will talk about what precision medicine is, its important components, global efforts for precision medicine, as well as precision medicine initiatives for Filipinos, and end with some key messages. Now, these definitions capture what precision medicine is. Its power lies in its ability to guide healthcare decisions toward the most effective treatment for a given patient, and thus improve care quality while reducing the need for unnecessary diagnostic testing and therapies. In this manner, preventive or therapeutic interventions can then be concentrated on those who will benefit from these therapies, sparing expense and side effects from those who will not. The components of precision medicine include disease prevention, which is predicting disease risk before symptoms manifest, disease diagnosis, which involves timely identification of the cause of an illness, and disease treatment, which refers to being able to provide optimal treatment for a patient. At the center of precision medicine are efforts to understand how variations in our genes influence our health. And so it harnesses the power of the human genome. The genome is unique to each one of us. Our health and well-being are dependent on our uniqueness. And these inherent differences combined with lifestyle and environment influence our risk for developing disease or our response to medications. Precision medicine is primarily data-driven. It is powered by patient data, and we heard that from the talk of Dr. Iris. With omics technologies related to information such as genomics, metabolomics, proteomics, transcriptomics, a dynamic risk assessment and optimization of current and future health status can be made using immutable factors. Those are your genetic factors, and actionable factors such as behavior, as shown in this slide. The practice of medicine has always, for the longest time, been a one-size-fits-all. But human physiology is extremely complex, and guesswork inherent in the practice of medicine may reduce the efficacy of the interventions that are prescribed. As you can see here, patients with the same diagnosis are given the same drug with different responses. Some benefit, and some clearly do not benefit at all, while others experience extreme adverse drug events. Hospital admissions to adverse drug events have actually been high in the recent decades. With precision medicine, patients can be grouped by disease subtype, demographics, and clinical features, and using genomics and other omics technologies, lifestyle, health history, multi-level patient stratification can be done. And this ensures the delivery of the right intervention to the right patient at the right time. The promise of precision medicine has been delivered for many types of cancer, but this same framework is used for the development of precision medicine for other complex diseases that are common to most populations, such as heart disease and diabetes. Aside from precision therapeutics, let me just mention two other important applications: precision prevention and precision diagnostics. Now, this is a picture of what happens when we lack the knowledge and the tools to predict adverse drug events. This is an adverse drug event 2 weeks after using an anti-epileptic drug in this 11-month-old baby, and the drug is called carbamazepine. Carbamazepine is the leading cause of Stevens-Johnson syndrome in Southeast Asian countries. Stevens-Johnson syndrome is exactly what you see in this picture: a child with severe mucoblistering disease that can be quite life-threatening. The HLA-B*1502 allele has been reported to be associated with SJS and toxic epidermal necrolysis among the Han Chinese, Thai, Malay, Vietnamese, Indonesians, but this same allele has been found among Koreans and Japanese. And definitely this association is not present among people of European ancestry. With this example, we clearly see interethnic differences in genetic profiles. Carbamazepine prescribing information already contains information on serious dermatologic reaction and the HLA-B*1502 allele for patients by including one's genetic information, treatment can be made more precise and personalized. It's almost like having your name written on the drug prescribed to you. And currently, there are more than 250 prescription medication labels, which include information for people with certain genetic variations. Now, this is a good example of precision medicine for prevention. Dr. Capula and his team from the UP College of Pharmacy already did work on anti-epileptic drug-induced SJS among Filipino patients, and they found that the HLA-B asterisk 1521 allele that may be used as a genetic risk assessment prior to prescription for prevention of carbamazepine-induced SJS among Filipino patients. So let me move on to precision diagnostics. Now, this is the story of the 1 in a billion boy, Nicholas. After 2 miscarriages in a span of 15 months, Nicholas was born healthy to Mr. and Mrs. Volker. Shortly before his 3rd birthday, Nick developed a relentless fever and abscess. When he ate, unusual holes would open between his intestine and the skin, causing feces to leak into a large wound in his abdomen. Severely underweight, he arrived at the Children's Hospital of Wisconsin in 2007 with bony arms and a distended belly. At age 4, Nicholas was in the process of dying. He has survived more than 100 trips to the operating room, and this is Nick, enjoying life even with all the tubes connected to his body. Now, what happened to Nick was his diagnosis. They were able to determine the correct diagnosis by doing whole genome sequencing, which showed a mutation in the XIAP gene. This gene is the X-linked inhibitor of apoptosis. And because of that, they found that this XIAP gene codes for a protein that causes an immune dysregulation syndrome, resulting in early onset, rapidly progressing, and catastrophic inflammatory disease, bowel disease. He then had bone marrow transplantation. So he is the first child saved by genomic profiling for the diagnosis of a rare disease. This is Nick now growing up to be a normal boy. And so this is precision medicine in action for diagnosis of rare diseases, because it puts an end to diagnostic odysseys of undiagnosed conditions. And because of his amazing story, there's a book called 1 in a Billion, the story of Nick Volker and the dawn of genomic medicine, that's already in wide circulation. So this map shows the international endeavor for genomic medicine, for precision medicine initiatives. And since 2013, the governments of at least 14 countries have invested over $4 billion in establishing national genomic medicine initiatives to transform healthcare systems by integrating genomic technologies into clinical care. The implementation of precision medicine is a global responsibility. We may think that resource-limited settings such as our country may not seem to be an appropriate place to employ cutting-edge precision medicine approaches and technologies, but it is precisely in these resource constraints that make precision medicine highly relevant and perhaps even more practical than relying on traditional approaches. We need our own population-specific data to make precision medicine a reality in the Philippines. Why? Because there's an underrepresentation of non-white ethnic groups in scientific research and clinical trials. Human genomic databases are heavily skewed toward people of European descent, and this limits how these databases can be applied to genomic research and to the clinical care of diverse populations. Population-specific precision medicine projects can dramatically improve their representation in genomic databases, as well as provide evidence for the clinical utility of genomic testing for precision medicine. Please allow me to present some initiatives for precision medicine that have been already done for the Filipino population. Heart disease remains a top cause of mortality among Filipinos. In 2021, a population-based study showed that there is relatively good compliance in taking antihypertensive medications, and the government allocates a substantial budget to procure antihypertensive drugs. However, only 39% of patients have good control of their blood pressure. Studying the genes of Filipinos that may be affecting response to medications can provide answers we need to better manage our patients. Fortunately for the Philippines, the Department of Science and Technology Philippine Council for Health Research and Development has funded omics technologies for health projects that are important in building the foundation for precision medicine. Through the Cardiovascular Genomics Program, a genomic database for heart disease specific to the Filipino population has been built. With the data that we now have, we will be able to offer to a certain degree the right drug at the right dose for the right Filipino. This is in line with the Saktong Lunas para sa Saktong Pinoy initiative of the DOST. For some of the significant findings from our research, a variant was found. We found a variant in the Cutiongco-de gene, which is a gene that plays an integral role in maintaining arterial elasticity, which affects blood pressure. The loss of even one copy of the Cutiongco allele may result to an almost four-fold increase in risk of not responding to beta blockers, such as metoprolol. The FGF5 gene has an impact on blood pressure regulation, and one copy of the T allele of the FGF5 variant may result to 3.5 times higher likelihood of not responding to calcium channel blockers, while two copies of this allele predisposes an individual to 7 times higher likelihood, so double that risk of not responding to calcium channel blockers. This is a problem for me because I actually am taking amlodipine as my antihypertensive drug. Now, using genomics, we also explored why Filipinos have the second highest prevalence of low HDL-C in the world, which is an established risk factor for cardiovascular disease. We found that a variant in the GCKR gene, a gene involved in glucose metabolism, gives a 4 times more likely risk of having low HDL cholesterol, which of course, as you may all know, is the good cholesterol. So we want that to be the normal to high, in the normal range and not being low. Now, diabetes is also as relevant as heart disease because it ranks number 4 as a cause of mortality among Filipinos. And globally, 1 in 10 adults, or 537 million adults worldwide, have diabetes, and almost half are undiagnosed. So which means a person already has diabetes and he probably doesn't know it, but there's already some end organ damage that's happening. Diabetes is responsible for 6.77 million deaths in 2021. That's 1 death every 5 seconds. And over 3 in 4 adults with diabetes live in low and middle income countries, including the Philippines. The burden of disease in the Philippines is high, with a prevalence of about 7.1% in adults between 20 and 79 years old. So our studies show that variants in the CETP gene, as well as the CDKAL1 gene. CETP encodes the cholesterol royal ester transfer protein, a transporter of cholesterol and triglycerides. CDKAL1 gene, its function is still largely unknown, but these two genes the variants in these two genes increase the likelihood of developing type 2 diabetes among Filipinos by as much as 10 to 20 times more, or higher risk. So another variant in this AH1 LINCOO271 locus confers 2.5 times higher odds of being obese among those with type 2 diabetes. Variants conferring risk for complications of diabetes have also been found, and you can see it in this slide. We found 5 variants associated with heart disease and diabetes, increasing likelihood by as much as heart disease and cardiovascular disease and diabetes as much as 6 times per variant. And there are also variants in these genes that are associated with a diabetic nephropathy. Our clinicians have told us that a biomarker for these types of complications would be very helpful so that they can direct their treatment, be more aggressive in preventing the secondary complications of diabetes. So this is for nephropathy, and this is for retinopathy, these 2 genes, and another gene, the PON2 variant, which increases the likelihood for peripheral artery disease by almost 5 times. We've hidden all the exact variant numbers because we are still working on the IP protection of those variants. A cancer genomics program is also in place, and genetic testing services at the PGC is about to commence for hereditary cancer gene testing and also for tumor profiling. A big part of this program is the development of companion diagnostic kits that are tailored for Filipinos. This is to make genomic testing available, affordable, and accessible to every Filipino. I just wanted to show you some of the precision medicine initiatives for cancer that have been funded by the Department of Science and Technology, Philippine Council for Health Research and Development. We're doing work on breast cancer in the Philippines, gene expression profiling of breast cancer among Filipinos, and development of breast cancer mammosphere assay toward individualized care cancer management. The CANDLE study, which is early cancer detection in the liver of Filipinos with chronic hepatitis B using AI-driven integration of clinical and genomic biomarkers. The detection and functional characterization of these KRAS, NRAS, BRAF, and PTEN gene mutations among Filipino colorectal cancer patients. We did find a lot of novel mutations in our population of patients, Filipino patients with colorectal cancer. And Clinical Proteomics for Cancer Initiative, a proteomics-based discovery of non-small cell lung cancer biomarkers and drug targets in the Philippines. As I conclude this presentation, developing countries with limited resources like ours, we have the most to benefit from precision medicine, as we cannot waste precious resources from therapies that clearly do not work. Filipinos can benefit from the Saktong Lunas para sa Saktong Pinoy program. But there is still a lot of work to be done. And we have 2 major challenges, because we have to make sure that precision medicine will be inclusive and equitable, especially as we anticipate the full implementation of the Universal Healthcare Act. And the other challenge is that we have to come together and come up with our own Filipino reference genome sequence to overcome a big barrier for precision medicine. This is a forthcoming project of ours at the Philippine Genome Center. It's called the Filipino Genome Project, or the Filipino, an initiative to sequence 7,641 Filipino genomes representing the islands of the Philippines, for us to have an accurate database for the Filipino population. International collaborations in research are essential, and are strongly encouraged, but we do not have to keep on transporting our DNA to our foreign collaborators. Through government support, we now have the capability to do genomics work ourselves and train the next generation of Filipinos to pursue academic and research excellence for the benefit of the nation. We need to remember also that our DNA is our story. It is our story as a people. And the DNA of our DNA belongs to our national treasure. Thank you very much. And these are my key messages. Precision medicine guides clinical decision-making and focus specific treatments on those most likely to benefit while sparing others the cost and potential side effects. There are already several precision medicine initiatives in the country that will help us generate our own population-specific data, which will provide evidence for the clinical utility of genomics for precision medicine. And the Saktong Lunas para sa Saktong Pinoy has to be inclusive and equitable. Thank you very much for your kind attention. Magandang hapon po muli.
Thank you very much, Doc Eva. I absolutely salute your work in precision medicine. You and your team's work. Mabuhay po kayo. Now, before I call on Dr. Dindi for the open forum, the very, very quick open forum for your talk, may I just acknowledge these doctors who are with us today, and maybe they have questions for you also. We do not know. So, may I acknowledge Dr. Hian Kua, Hospital Director of Manila Doctors Hospital. Also from Manila Doctors, Dr. Arlene Ledesma, President of Manila Doctors Hospital. Dr. Dante Morales, Director of Manila Medical Services. Dr. General Joseph Acosta, Metrobank Foundation Outstanding Soldier from San Juan Medical Center. Hello, sir. And Police Colonel Susan Hala, Metrobank Foundation Outstanding Police Officer and PNP Forensic Group Advisory Council. So good morning, good afternoon to all of you. We also have here with us General Dr. Komi Pagunuran, Metrobank Foundation Outstanding Soldier. So your audience are not just medical doctors, but also police officers, teachers, and soldiers. So Dr. Dindi, are you ready for the open forum?
Thank you, Dr. Eva, for your good lecture. We're opening our Q&A for the questions for Doctora. There's one question here.
Maybe you need to speak a little bit louder.
Okay.
Dindi, I don't hear you very loud.
Not yet, sir. I'm just starting po.
All right.
Sir Nick, is that you? Hello po, Sir Nick. How are you?
Yeah, that's Sir Nick.
Thank you, Dr. Eva. Thank you for your very good work. Especially, we wanted the word Filipino. It's really Filipino. So we have all our data. The question is, do you have? Can we use this data now for the clinics? Will the clinicians use this data? And looking forward in having sakto Filipino for all. Thank you.
Thank you, Dr. Dindi, for that question. I think it's very relevant because most people think that once we have these findings and discoveries that we can readily translate it to the clinics. Not yet, not quite yet, because it needs for that translation to happen, we need two things. And one is actually to be able to validate it in a larger cohort of Filipino patients and replicate it also in the different regions. We have different ethno-linguistic groups in the country, and they have to be well represented as well. And the second is, of course, what we did through this research is we employed high throughput genomics technology to be able to find those variants, which was like looking for a needle in a haystack, right? But after we have found these significant markers, we have to find the right technology to be able to put it into point of care diagnostic kits, Dr. Dindi. So not quite there yet, but we are getting a lot of support from the cardiologists in the country, like Dr. Morales in the audience, a lot of the people. Yesterday, I was with the Philippine Heart Center people, and they would like to participate in the validation studies for all these significant markers that we've found in our population, from our study population. So we need to see how those markers are in the real world setting, so in the country. So that's an important step before it can be used in the clinic, Dr. Bindi. Thank you.
There's a question from Dr. Morales. How far are we from genome engineering? Precise diagnosis with genome sequencing, but I look forward to what we can do as treatment. Thank you and congratulations.
Thank you, Dr. Morales. If you're talking about CRISPR technology for developing therapies, at the moment the CRISPR technology research being done in the country are mostly, I would say, in the fields of agriculture, biology, not yet for the medical field. I think at the moment, what we would like to strengthen would really be in doing diagnostic work, because there are a lot of medicine out there already coming from, that we have available. We just have to make sure that the patients who will be receiving those type of medications that are available and have been found to be effective suits this patient according to his or her genetic profile. So that's the one that we're strengthening right now. But I hope, like you, that soon we will also be able to participate in discovery for new drugs, novel treatment. And a big step to first, before that happens, is really understanding the biology of the disease. So, and especially for our population, which can be different from other population groups. So I hope I was able to answer your question, my dear Professor Dr. Dr. Morales.
There is another. What are some limitations of precision medicine that impact on the Filipino culture and gender sensitivities?
Yes, thank you for that question. It's a hard question, but I think what we're trying to do, as I mentioned, like for example, in the Filipino project, we are going to sample the whole country. We're not going to limit it to Metro Manila or our surrounding areas, but we would like to have representation from the different regions, knowing that even recognizing the fact that we're a mixed population. No, we have Malay, we have Chinese blood, we have some of us can have some Spanish blood. So we'd like to be able to create a database that will be inclusive to everyone, to break down those barriers for culturally as well as for gender sensitivity, because for gender, a representation of both male and female in that genome, in that Filipino Genome Project.
Thank you, Dr. Eva, for her very kind questions. There is another open forum after the reaction from, of course, the PCHRD director and the former secretary. We will see you later, Dr. Eva. And back to you, Crystal. Thank you for the questions. There are more questions here at Q&A and chat in the chat box. We'll answer them later. Thank you very much.
Thank you.
Thank you, Dr. Dingy, and thank you, Dr. Eva. We will now proceed to our last but not the least speaker for this afternoon. So may I invite Dr. Maria Minerva Calimag, MD, MSc, PhD, 2021 Metrobank Foundation Outstanding Filipino Awardee. She's also a professor of pharmacology and clinical epidemiology at the UST Faculty of Medicine and Surgery and the UST Graduate School. She's a senior researcher at the UST Research Center for the Health Sciences and the UST Research Center for Social Science and Education. She will deliver her presentation with the title Population Pharmacogenomics and Precision Public Health. Dr. V, good afternoon.
Good afternoon. So my topic is on population pharmacogenomics and precision public health. Expanding horizons. For a while. So we live in a whole new VUCA world where it is, you have volatility, we have uncertainty, complexity, and ambiguity in everything that we do. There are many challenges in medical practice, particularly the explosion of medical knowledge. We have the changing healthcare environment, lots of societal expectations. Of course, our focus on patient safety as well as healthcare professional safety. We have the rapidly changing technology environment, which we have seen with the presentation of Iris, and the value of big data, artificial intelligence, machine learning, and the Internet of Things. and these challenges, of course, posed by our pandemic. In precision public health paradigm, healthcare decisions are made at the level of populations as opposed to individuals. And it provides one way for the genomics revolution to directly impact health outcomes in the developing world. Population-centered approaches to pharmacogenomics can help realize the promise of precision medicine in resource-limited settings. And here, of course, we require a deep understanding of local population genomics. And you've heard Dr. De La Paz said about we're going to actually test the whole country. And the good thing about it is that you only need a test, no, perhaps once in your lifetime after you have been profiled, no. And there is a need to investigate the population genomics of genetic variants that mediate drug response in an effort, of course, to inform healthcare decisions. These are the old medical records. And here we are moving towards electronic medical records. And the adoption, of course, is out of maybe about 2,000 hospitals in the Philippines, only 200 have electronic medical records. So there is really a need, no, for us to move forward and hasten the adoption. And why is that? Because patients' medical information from a variety, of course, of information systems for physicians, laboratories, clinics, hospitals, and treatment sites provides a holistic view of the patient's health history, also provides a wealth of information that can be used to improve care and outcomes. And while we have this, legacy data should be able to, while promoting confidentiality, of course, and privacy, still there is a need to make this data interoperable, meaning it can be read, no, by different systems. So we have the administrative order actually between DOH and the PhilHealth, no, to adopt the interoperability of data between the two systems. This has been said, artificial intelligence, an area of computer science that emphasizes the creation of intelligent machines that work and react like humans. And of course, machine learning, an application of artificial intelligence that provides systems the ability to automatically learn and improve from experience without being explicitly programmed. And we use this for, of course, improve also for the improvement of patient safety initiatives in the clinics. Now, EMRs and artificial intelligence, where clinical diagnosis can be efficiently extracted from the identified EMRs. The identification is necessary for, of course, patient privacy, no? And confidentiality. Now, through the application of AI algorithms, integrating diagnostic codes, clinical laboratory data, and medication histories, now you have the ability to replicate known associations previously characterized in disease-specific research cohorts. Imagine doing research and you have to go to the record section and open up all those records before. Now we can easily do it on our desktops, no? So data derived from EMRs are, of course, highly accurate for quantifying disease phenotypes as well as treatment outcomes. We can monitor onset and rate of disease progression, as well as monitor efficacy and toxicity of drugs that have been given to the patient. So what is real-world evidence? What is it? And what can it tell us? This is big data and real-world medicine, no? So we have data coming from varied people with varied phenotypes and genotypes, no? And we used to say that the randomized controlled trial is the best evidence, but because they are done in controlled settings, no, we look at patients as and the outcomes as if one size fits all. But in randomized controlled trials, they only work for 60% of the population at best. When we do individualized approach, drug or dose chosen for a patient, 40% of the population may have increased risk of ABRs because of gene variation. So this is real world. Here, we know, of course, we said that the generalizability of randomized controlled trials is limited, so the external validity is limited, no? Because there are other extraneous effects that can lead to variability in treatment outcomes, like, for example, comorbidities, co-medications, what else? Of course, compliance, no, of our patients, no? Okay, so the research community has called for the use of patient outcomes data in medical evidence for many years, but the concept of real-world evidence is a more recent phenomenon. And most proponents associate real-world data as data that is derived from medical practice among a heterogeneous set of patients in real-life practice settings, such as clinical data from electronic health records. So, but actually, this is the continuum of real-world evidence, no? Not just electronic medical records. We have, of course, the claims data analysis. So this can be coming from PhilHealth, no? And then retrospective medical record review coming from EMRs. And of course, patient registries, like, for example, cancer registries, no? Disease-specific registries, no? And this is the real-world evidence value communication that comes after. So these are RCTs, and this is real-world evidence, no? So in real-world evidence, we have broader and more representative of the patient population. There is we see how real-world patients adhere to medication regimens and their compliance, and demonstrate the benefits of a drug in everyday clinical practice. So this is ideal for showing value within local health economy. So here, of course, with RCTs also, we know that we can have significant cost, no, associated with putting up a clinical trial. So here's the difference between our RCT and our real-world evidence, no? So the key word here is, does the drug work in real life, no? In actual clinical practice, there might be variability in patterns, no? And then, of course, the active comparator is the usual or standard of care. So the rapid growth in information communication technology and the power of the internet has strongly impacted the service delivery models of today's global environment. Healthcare information technology and genotyping technology are both advancing rapidly and creating new opportunities for medical and scientific discovery. So here, by linking biologic materials to comprehensive medical records, no, we can have, for example, also large multi-institutional biobanks. We can advance the field of pharmacogenomics through three distinct mechanisms. One is retrospective assessment of previously known findings in clinical practice-based setting, the discovery of new associations in huge observational cohorts, no? So, and prospective application in a setting capable of providing real-time decision support. So we can have clinical decision support, AI mediated algorithms. So again, big data refers to large, diverse sets of information. These are extremely large that are analyzed computationally to reveal patterns, trends, and associations, no? And of course, big data grows exponentially with time, no? So this is how huge big data is. So again, just to emphasize the characteristics of big data: volume, variety, velocity or the speed by which it is generated, variability that refers to the inconsistencies, and of course the veracity, the truthfulness of the data set. So we are here, somewhere here, and perhaps we'll be talking about yottabytes of structured as well as unstructured data by the year 2030. So here is big data in public health systems, so not just within hospitals, but in public health systems. So we communicate, for example, infectious disease surveillance systems, for example, tuberculosis control system, HIV and sexually transmitted infections surveillance systems. So all of this, we need to take into consideration when we talk about big data. So it will act as a medium for tracking, controlling, research, and prevention of many diseases. So here are the big data sources, patient health records, x-rays and CT scans, the DICOMs, and then the infected case histories, for example, and the outbreak area information. And then they will enter into the big data processing of population data, and then the outcomes will of course be big data applications, prediction of outbreaks, spread tracking, disease diagnosis, vaccine and drug production. And this is especially, of course, we're in the midst of the COVID pandemic, and what we see on a daily basis, and what we analyze at the Health Technology Assessment Council are all related to big data applications. So here is also an online knowledge resource for pharmacogenomics. Okay, so this is Pharm GKB, Okay, so it focuses on annotation, aggregation, integration, and dissemination of pharmacogenomics peer-reviewed literature, drug labels with pharmacogenomics content, and drug prescribing guidelines based on patient genotypes. So we have big data, pharmacogenomics, and personalized medicine, which has already been discussed. Then, of course, instead of saying personalized medicine, we say precision medicine, because the focus is on identifying which approaches will be effective for which patient based on genetic, environmental, and lifestyle factors. So here at the center of the interaction between drugs and genes are called pharmacogenes. So we have the absorption, distribution, metabolism, and excretion, about what our body does to the drug, which we call pharmacokinetics, and what the drug does to our body, which refers to the actions and interactions, that is binding, activation, deactivation, upregulation, and downregulation of a drug, with biologic molecules in order to alter the physiology of a disease, or pathophysiology. So here, from pharmacogenetics to pharmacogenomics. So while pharmacogenetics refer to the study of the genetic basis for variability in drug response, pharmacogenomics is the use of genetic information to guide the choice of drug and dose on an individual basis. Di ba? Nagbago lang yung ethics at saka omics, But they refer to the two different things actually. So we have from single gene to small number of genes to complex biological pathways and whole genomes. Okay, so here additionally, the results of previous pharmacogenetic research efforts have been formulated into clinical guidelines that are beginning to impact, of course, our healthcare on the level of whole populations. Made possible, of course, by new data sets containing linked genotype and electronic medical record data. Okay. So candidate genes and recent genome-wide association studies suggest that susceptibility to a range of common adverse events, including cardiac, like MI, ventricular dysfunction, atrial fibrillation, neurologic, and renal, among others, is genetically and epigenetically determined. No? So now we are opening new horizons, no, in the understanding of diseases. So here we have inter-individual variation in drug response, no? And then pharmacogenomics, of course, affect not only therapeutic efficacy, but also disease susceptibility and drug development. So here, for example, phenotypic consequences of a deficient CYP2D6 phenotype includes, for example, increased risk of toxicity to antidepressants or antipsychotics, which are catabolized by the enzyme, or lack of analgesic effects of codeine because this is anabolized by the enzyme. So, if there is increased metabolism, decreased metabolism, no, then you have increased risk for toxicity because the drug accumulates in the body, no? So if there is increased metabolism, then there will be lack of analgesic efficacy. So there are also ultra-rapid phenotypes associated with extremely rapid clearance and thus decreased efficacy of antidepressants. So human genetic variations, these are the single nucleotide polymorphisms, or the SNPs, no? And then we have the microsatellites, to a broader category of structural genetic variants, which include repetitions in short sequence genes, no? And then insertions and deletions, inversions, and the copy number variants, no? All of which may or may not be associated with a specific phenotype. So these are the CRISPRs, no, which is an RNA-guided targeted genome editing tool, no, and as Dr. Eva said, no, it is still being used mostly in agriculture, no, but it's coming, I'm sure. So here, of course, we have the rare genetic variants responsible for more than 1,500 monogenic disorders, no, such as hypertrophic cardiomyopathy, the long QT syndrome, no. If we give them drugs, of course, that affect the QT interval, no, like the macrolides, for example, then we can have severe complications. And then, of course, familial hypercholesterolemia, the concept whereby we have even fat individuals with low cholesterol and even thin individuals with high cholesterol may be due to familial hypercholesterolemia. I think our family has this, no? Okay. So to be classified as a polymorphism, DNA sequence alternatives must exist with a frequency greater than at least 1% in the population. About 15 million SNPs are estimated to exist in the human genome. Okay. So here, for example, no, several alleles may be expressed in different percentages, no. So polymorphisms may directly alter the amino acid sequence and therefore potentially alter protein function and alter regulatory DNA sequences, no, that modulate protein expressions. Sets of nearby SNPs on a chromosome are inherited usually in blocks, and they are referred to as haplotypes. So this is P3, or personalized pharmacogenetic profile, where you have all patients with the same diagnosis, not all respond to the same medication. So if the P3 is normal, you treat with conventional dose. If it is moderate risk, no, you consider an alternative drug or vary the dose. And then, of course, if there is an elevated risk, then you treat with alternative drug or dose. So how is pharmacogenomic information being used? So there are, for example, abacavir, where you have HLA gene tests, no, for HIV patients, and the gene is HLA-B 5701, no? And then the drug targeted related gene test for trastuzumab and HER2/neu for breast cancer patients, mercaptopurine for drug metabolism related gene test for patients with acute lymphoblastic leukemia. And then we have irinotecan, no? And the gene UGT1A1 28 for colon cancer patients who may need lower doses as part of their combination chemotherapy regimen. And then there is combined, where you have both metabolism and target gene tests for, let's say, the blood thinning drugs, warfarin and clopidogrel, and CYP2C9, no, plus the VKORC1 genotype as variants might influence response to the drug. And drug metabolism related gene test, no, for the PCSK9 inhibitors, alerucumab and evolucumab, for those with familial hypercholesterolism. These are other examples of genetic polymorphisms involved in variable response to drugs. So here, pharmacogenomics and big genomic data from lab to clinic and back again, you will see that the cycle repeats itself, no? First, you have, of course, clinical research, then you have your clinical guidelines, and then for public health, there is a need for public health policy, and through the use of also personal health record, you have quality measures based on clinical decision support. And here on top, no, we will see that first you have the personal health record, and then you have the electronic health record, the health information exchange, where we need the interoperability, and then the national and international health analytics. So this is in a nutshell, no, actually what population precision health, no, is all about. Okay, so for COVID-19 response, precision public health as key tool, no, so we can many fundamental questions remain, such as when can employees be deemed to have non-essential return to work? How can children safely return to school, no? And who would be first to receive a vaccine once it becomes available? So information about who is at highest risk of hospitalization, intensive care unit admission, and death based on age, sex, race, ethnicity, and underlying conditions, no, is now becoming available. So here we accrue data, no? And the accrued data suggests that it might be possible to better target interventions for populations through precision public health, no? And here, precision medicine uses genomic and other personalized data information to provide the right treatment to the right patient at the right time, no? So also precision public health is an emerging discipline that uses extensive population-specific data to provide the right intervention to the right population at the right time. Okay, so precision public health, no, again, uses data from traditional and emerging sources to target interventions for populations by person, place, and time, in part with a focus on reducing health disparities. So, for population pharmacogenomics and precision public health, there is a potential of these technologies to stimulate drug discovery in the case of rare or orphan diseases or neglected diseases, as has been shown, to reduce also acute adverse drug reactions in infectious disease treatment and prevention, and to improve global public health, especially among the vulnerable population. There is a potential to predict patients' response to drugs, to develop customized prescriptions, to minimize or eliminate adverse events, and improve efficacy and patient compliance, and improve rational drug development. To improve the accuracy of determining appropriate dosages of drugs, to screen and monitor certain diseases, to develop more powerful and safer vaccines, and to allow improvements in drug discovery and development. So we should develop strategies to better direct the implementation of population pharmacogenomics for precision public health through by responding to the realities of populations of the developing world for social, cultural, and political acceptability, as well as local health burdens. No? So pharmacogenomics has great potential to optimize drug therapy. Newer molecular diagnostic tests will have to be developed to detect polymorphisms, noting that pharmacogenetic tests need only be done once during your lifetime. And then pharmacotherapeutics decisions will soon become fundamental for diagnosing illness and guiding choice and dosage of medications. So the book world challenges us to find our own way to vision, understanding, clarity, agility, and adaptability. Thank you very much.
Thank you very much, Dr. V. I wasn't able to understand a lot of the terms, but I'm sure our audience are they know about these terms and they are absorbing this like sponge. So thank you very much, Dr. V, for that. May I now call on Dr. Dindy Hogar for questions. I saw some questions in the Q&A box. So Dr. Dindy. Are you on mute, Dr. Dindy? I'm not able to hear your words.
You cannot hear me?
Oh, there, I can hear you now. Please go ahead.
Okay. Hi, ma'am. Good afternoon, Dr. Calimag. How are you? Thank you for that lecture. The question is not putting you on the spot as future MA president. There are concerns of the Philippines geographical and topographic challenges of the Philippines. How do you now integrate data of pharmacogenomics and integrate this to a better public health in the Philippines? Thank you.
We really need to digitalize everything, no? You mentioned about PMA. My main goal is really to make everything digital for the association, because we really need to have the big data. If, for example, we can have all of our physicians moving towards better treatment in public health settings, no, we can have the patients also, no, data be collected at source. We have really a very hard topography, no. There are many GIDA areas. For example, Dr. Sudabarius in Tawi-Tawi have been there, no. They have to make boat rides in order to get to the far-flung areas. And another issue is, as was mentioned by Dr. Eva, was language barrier. We have at least 100 plus ethno-linguistic strands in the Philippines, no? And we are, of course, promoting that if you do public health, you should be able to speak the Philippine-based language in the area. In the meron pa tayong mountains, hindi lang yung sea, no? Meron pa tayong mountains where you have to trek no, for 1 to 2 hours, for example, coming from Baguio to the different far-flung areas, no. So, yeah, collecting data for population-based public health can be a challenge. But once it is collected, you just profile once, and then we can have, for example, knowledge about how to treat diabetes, how to treat cardiac diseases for all our Filipinos to make Dr. Eva's vision come true.
Okay. Dr. Calimag, pharmacokinetics and pharmacodynamics are important in evaluating medicines in the country. The processing is expensive, thus we are not able to do this except in a small percentage of medicines in the country. And sad to say, much less for supplements, if at all done. How can we improve this situation? Where we can depend on foreign data, but the ratio differences. Congratulations, Dr. Morales. Doctora.
Yes, Dr. Morales, exactly. No, we cannot depend on foreign data because as we have seen, no, genetic profiling differs for different ethnicities. And multi-ethnic kasi ang Filipinos. Meron tayong Malay race, meron tayong Spanish, meron tayong iba-iba, no? So, actually, for bioavailability, in terms of bioavailability for kinetics studies, we cannot also do it on a large scale, no? So, tama, that is another challenge, no? So, ang isa kasing problem natin is actually how to detect the bioavailability of drugs because 80 to 120 ang range ng bioavailability ng gamot sa katawan natin, no? So a drug may be able to give only say 90%, no, be bioavailable for only a certain percentage and still pass tests, no, bioavailability tests. So this is another challenge really.
Thank you, Doctor. So, are we there where? That was the question. Are we there yet? Hindi po, ang tanong, are we there where? Doctora. Very good question.
Or somewhere out there. We're still, the future is still to come. Diba?
Yes. So, the population pharmacogenomic is really good for precision public health. We've seen it, as you mentioned, in the diabetics and, of course, the cancer therapy. They're signaling to us because there is an open forum after the reactors. We'd like to thank you, Dr. Calimag, for answering most of the questions. There are more questions coming up. And of course, I'd like to remind everybody that at this point, we have to revisit your notes and of course questions in mind that is for clarification, and of course your comments and insights. Let's type it in your chat box in question and answer part. But at this point, we are thanking Dr. Calimag for now, and we will see you later in a while at the second open forum. Thank you, Dr. Calimag. Crystal, back to you. Thank you.
Thank you, Dr. Dindy, and thank you, Dr. V. See you later. So to proceed, we will be moving on to two of our reactors this afternoon. We have Dr. Manuel Dairit and Dr. Jaime Montoya. So we will be starting with Dr. Manuel Dairit. He's a member of the Technical Committee on Medical Education of the Commission on Higher Education, and he was the former Secretary of the Department of Health. So, Dr. Dairit.
Good afternoon to everyone, ladies and gentlemen. friends and colleagues. Thank you very much for this opportunity to give a few remarks today. Thank you very much to the Metrobank Foundation and of course to Mr. Chito Sobrepeña. Thank you and congratulations to our Metrobank fellows and speakers, Dr. Iris Isip-Tan, Dr. Eva Cutiongco-de, and Dr. Minerva Calimag. Their presentations give us an idea of the landscape for the future, where telemedicine, genomics, robotics, big data will more and more become a part of our lives. I graduated from medicine 45 years ago, a long time ago. But looking back, at the time, you know, the CT scan had only been recently invented in 1971. The first CT scans in this country, I believe, arrived in the late 1980s and 1990s. And you know, at that time, there were no laptops, there were no mobile phones, there were no smartphones. And of course, the internet did not exist. And the Human Genome Project, which started in 1990 and was completed 13 years later, had not been started at all. So I am in awe at these new technologies. You know, they have changed the course of our civilization definitively. But I sometimes also wonder at what they really mean for us in terms of making us better persons, better communities, better global citizens of this planet. Certainly, these technologies may provide value in that they help improve healthcare. But I doubt that they will save us from ourselves and the new problems that we human beings create for ourselves and the world around us, if you allow me to be philosophical at this point. So now, we are in the year 2022 and just slowly moving out of a pandemic that ironically, all our advanced technology could not prevent or even contain. So what did the COVID pandemic teach us about ourselves and our health systems and our societies? If you look back, at least within the Philippine experience, I think of the pandemic as divided into three phases. The first phase, 2020, when we had to grapple with the initial Wuhan strain, the wild virus. We were unprepared. In 2021, that was the year of the variants. There was Alpha, Delta, and later in the year, Omicron. But also, that was the year of the vaccination. And of course, 2022, the year of Omicron, and hopefully the end of the pandemic and endemicity, most likely, of the Omicron variant. So what were our observations for the pandemic? Well, not to belabor the obvious, our systems were outmoded and unprepared. Facilities and health workers were not prepared of what was to come. There were no PPEs, no lab capacity, no testing capacity, no data systems, no digital assisted contact tracing. In this first year, 2020, we lost many relatives and friends to COVID-19. The social reactions to the pandemic and our response to it, we responded as best that we could, given our circumstances. And our circumstances seemed to dictate that lockdowns were the order of the day, because our systems could not contain it and were being overwhelmed, particularly in the hospitals. And with the lockdowns came the drop in economic activity. We, of course, launched our vaccination campaign, and then we were faced with pro-vaccine and anti-vaccine sentiment, and protest even against vaccine mandates. But interestingly, within these circumstances, new technologies were deployed rather quickly. These new technologies included, well, the mRNA technology for vaccination, which had been around for many years and were put to use to produce a vaccine within a year. There were digital apps that had been invented to help contact tracing. Genomic sequencing of the coronavirus became more widespread so that we could track the variants. And of course, there was the rise in telemedicine. We found hope in these new technologies, but also these new technologies did not necessarily prevent or protect us from what was to come. We can also think that during these pandemics, the inequalities in our country and in the world actually got exacerbated. So we ask ourselves, how has the pandemic affected the various sectors of our society? How did it affect businesses, small businesses as well as large businesses? Many businesses failed, but actually many other businesses actually succeeded and grew richer. How has this pandemic affected the farmers and the fishermen? How has it affected the daily wage earner? How has it affected children who have not been able to go to school? And if you think of inequalities at the global level, how have these inequalities played out for all of the countries in our planet? Just the availability of vaccines is an example of how these inequalities actually got exacerbated. Many poor countries didn't have enough vaccines to immunize their population. And finally, this pandemic actually gives us a call to expect more pandemics in the future. So as these new viruses emerge and new pandemics become a possibility, interestingly, so have new technologies come up. And this has been really what our speakers have elaborated on today. So how should we think about these new technologies? What are the questions that we might pose? And let me just pose 3 questions. I'm not going to answer them, but I put them out there for us to think about and to reflect on. Let's start with a question to our experts. What will change, for better or for worse, as these new technologies come on stream and become available to more and more people? How will these technologies ultimately benefit individuals and populations? My second question would be for our country's policymakers and health systems planners. How will investing to develop and propagate these technologies in the country help achieve the aspiration of health for all Filipinos? In other words, how do these technologies fit in the context of universal healthcare? And finally, let me pose a question to our educators and those government agencies which regulate health professional education in our country. How will these new technologies affect how the next generation of health professionals are to be taught and made ready to practice their professions in the future? 3 questions to reflect on, even right now, as we phase out of this pandemic and enter another brave new world that is waiting for us. Thank you very much, and good day to all.
Thank you for that, Dr. Diary. You're right, you have come so far in terms of technologies, but this did not prevent what happened with the pandemic. This will not stop us, especially our 3 awardees and their team, but this will challenge us more to be more prepared for the next pandemics. As Dr. Diary said, this is not the first one, but it will help us to be more prepared for the next ones to come. So for the next reactor, may I call on the Executive Director of the Philippine Council for Health Research and Development of the Department of Science and Technology, Dr. Jaime Montoya.
Metrobank Foundation President, Mr. Aniceto Sobrepeña, Metrobank Foundation Outstanding Filipino Awardees, Dr. Iris Thiele Isip-Tan, Dr. Eva Marie Cutiongco-de, and Dr. Maria Minerva Calimag. Ladies and gentlemen joining us today, magandang hapon po sa inyong lahat. On behalf of the Philippine Council for Health Research and Development of the Department of Science and Technology, I would like to thank the organizers of the event for inviting me to share my reactions to the 3 presentations from the results of Filipino breakthrough research studies. As you may already know, these 3 doctor researchers have been very close to the DOST PCHRD. They have been our partners in implementing several projects to make life better for the Filipino. To mention a few engagements with them, we collaborated with Dr. Isip-Tan in conducting the Social Media Summit since 2015, and she actually introduced to us the use of visual abstracts in disseminating research info in social media. With that, we were able to launch the Visual Abstract Making Contest, which is now on its 2nd phase. Dr. Cutiongco-de is an active member of the Research Agenda Management Committee of the Philippine National Health Research System, and a lot of her research, including those in genomics, have been supported by the Council. Dr. Calimag was once very active in helping us train researchers in writing journal publications, and now she is appointed as a scientific member of the National Ethics Committee. Investing in health technologies such as genomics for precision medicine and digital health and/or artificial intelligence can lead to major medical breakthroughs. Similarly, increasing our national capacity through R&D can potentially save millions of lives as we discover better healthcare practices or medical interventions. As the primordial source of health research leadership and direction in the country, the Department of Science and Technology, Philippine Council for Health Research and Development, provides an avenue for visionary scientists who dedicate their craft for the improvement of quality of life of each Filipino. In addition to strengthening the country's capacities for health, and to ultimately to enable Filipino breakthrough healthcare solutions to reach global competitiveness. The PCHRD, created in 1982 and legally strengthened through RA 10532, is one of the 3 sectoral councils of the Department of Science and Technology. It is a forward-looking, partnership-based national body responsible for coordinating and monitoring health research activities in the country. The PCHRD envisions to be the recognized leader provider of research-based solutions and innovations to address health systems needs by 2028. Our mandate is to formulate policies, plans, programs, projects, and strategies for health S&T development, program and allocate government and external funds for research and development, monitor R&D projects, and generate external funding. As the national coordinating body for health research, we provide central direction, leadership, and coordination of health research activities. PCHRD provides grants for researches aligned with the National Unified Health Research Agenda, or NURA, which was launched in September of 2006 to serve as the country's template for health research and development efforts, specifying the areas and topics needed to be addressed in a 5-year scope. The current agenda regime covers 2017 to 2022. As the NURA is ending its current chapter, we are now focusing more on health technologies in the formulation of the upcoming agenda for the next 5 years. On digital health, the presentation of Dr. Isip-Tan invites the utilization of innovative technologies to improve delivery of healthcare services. The PCHRD is one with Dr. Isip-Tan in this perspective. The Council identifies the Digital and Frontier Health Technologies Program as one of the priority areas for research and development. The Council aims to invest in disruptive technologies brought about by the Fourth Industrial Revolution in order to make healthcare service and delivery more accessible and equitable for Filipinos. We are venturing into big data analytics, AI in healthcare applications, and cybersecurity and protection of health information systems. This is due to the inherent characteristic of digital health and artificial intelligence-driven health solutions to evolve continuously and provide breakthrough technologies that has the capacity to simplify access to healthcare and streamline service delivery in health, while making healthcare cost-efficient and far-reaching. Some notable examples of projects that utilize these technologies are the following: FASTER, or the feasibility analysis of syndromic surveillance using spatiotemporal epidemiologic modeler for early detection of diseases, spearheaded by the Ateneo de Manila University, currently being used in the pandemic response as a decision support tool, had been developed as a hub in the pandemic response for different data sources, thereby providing a rich layout of integrated information that will facilitate in understanding the spread of diseases. Currently, it is being utilized as a decision support tool by the IATF in this time of pandemic, as it takes a multidimensional approach in modeling disease spreads by using localized indices from Philippine health records and by integrating other data sources, including but not limited to disease and event surveillance systems, electronic medical records. Meanwhile, Aruga sa Batang May Cancer utilizes ICT to bring health solutions closer to pediatric cancer patients, much needed in this time of pandemic due to travel restrictions. The platform developed integrates a learning management system with learning materials focused on palliative care for healthcare professionals and primary caregivers of pediatric patients with cancer, a pediatric oncology registry for health facility administrators, and a telemedicine platform. The previous slide shows only 2 examples of projects already being integrated into a healthcare system. However, with the advent of disruptive technologies born from the Fourth Industrial Revolution, there are still emerging fields of technologies to be expected with potential for driving innovative and groundbreaking digital and AI-driven health solutions. Ultimately, through the implementation and integration of these solutions in the healthcare system, healthcare service delivery is envisioned to be more cost-efficient in terms of providing healthcare services and providing solutions to health needs of both the individual and the community, equitable in access and distribution of resources, no matter the location and circumstance, efficient, streamlined process in providing and acquiring health solutions in the shortest possible time, and encompassing healthcare needs, whether it be acquiring healthcare or capacity building of healthcare providers. Another research priority of the PCHRD is the omic technologies for health, or omics. We recognize that our genetic makeup holds hints on how certain diseases will progress over time. The study of the Filipino genome, which is the entire genetic material of the Filipino, will reveal a wealth of information which can lead to the development of better ways and technologies in disease diagnosis, management, treatment, and prevention. With this, the PCHRD's Omics program aims to utilize omic technology platforms in generating meaningful information as input into the development of personalized precision medicine, diagnostics, therapeutics, and other technologies, and as a support to health and clinical practice guidelines and policies of the Philippines. With genomics, we can check whether the drugs we're giving really work for us and even develop our own medicines that will fit us better. On the larger scale, genomic information helps in monitoring disease outbreaks or epidemics, which is crucial in decision-making of our public health officials. The COVID-19 pandemic is a timely example of this. By sequencing of COVID-19 virus, we were able to identify variants and their location, and thus inform policymakers. Through genomics, we aim to develop new health products and services and strengthen the health clinical practice guidelines and policies of the Philippines. Mga lunas na sakto sa Pilipino. Realizing these benefits, the DOST and the PCHRD, in their shared vision of a healthier Filipino nation, has put premium investment in omic research. From 2015 to 2021, the DOST PCHRD has already invested 1.2 billion pesos to genomics projects and facilities for health research, and it is expected that more investments will come in for this priority area. The scope of omics ranges from multi-omics approach on health and diseases to translational omics research for precision medicine. With this, the DOST and PCHRD has invested in omics projects on non-communicable diseases, infectious diseases, genomic surveillance of SARS-CoV-2, maternal diseases, rare diseases, and even forensics and population studies. As an example, PCHRD has funded pharmacogenetic and susceptibility studies on diabetes and cardiovascular studies such as hypertension, high blood cholesterol, heart attack, and stroke. Having said this, we put more weight on the importance of the work of Dr. Eva Maria Conchocon de la Paz on precision medicine for Filipinos, and the work of Dr. Minerva Calimag on pharmacogenomics and real-world evidence. As challenges in health continue to rise, it is more imperative for innovations in health technologies to happen. The works and practices of Dr. Cutiongco-de la Paz, Dr. Calimag, and Dr. Isip-Tan prove how research on omics, precision medicine, and digital transformation impact healthcare in the Philippines, as well as set the landscape for health research for the next generation of Filipino scientists. We thank the Metrobank Foundation for duly recognizing the efforts of these Filipino scientists so that they may continue to show the way for more researchers, scientists, Filipinos to do things that will put the country and the people first and foremost. Visionaries like them are living manifestations that the journey harnessing the power and potentials of health research involves persistence, grit, passion, and innovation. They help PCHRD in its pursuit of better lives for Filipinos for a healthy Filipino nation. Thank you very much for your time and attention. And again, mabuhay ang ating mga outstanding Filipina scientists.
Thank you very much for that, Dr. Montoya. At this point, we are inviting Dr. Thiele Isip-Tan, Dr. Eva Cutiongco-de la Paz, and Dr. Maria Minerva Calimag to join us in the open forum. May I also invite Dr. Redindi Hogar to facilitate this discussion. Now, for our viewers, you know what to do. Please type in the chat, in the Q&A box, your questions, and also in the comments box for our FB live viewers. Dr. Lindy?
Yeah. Good afternoon. Welcome back. There's a question here for Dr. Eva, while the others are typing on their chat box. From Dr. Bautista, please comment on the genetic or chromosomal testing for recurrent pregnancy loss currently available at the NIH. Thank you, Dr. Eva.
Thank you for the question. We do have chromosomal studies, and we do that for one indication for doing chromosomal studies is really for recurrent pregnancy loss. We already, together with the obstetricians, we actually have some guidelines already that's going to be available soon to help clinicians know when the testing should be done and where it's available and how much this is and how much the test is. The other test that we are trying our best to make available soon is the chromosomal microarray, because that will allow us to study the product of conception and to determine whether the loss of the baby was due to a chromosomal abnormality. And in fact, in the new guidelines that will come out, if we do a chromosomal microarray, that would be an important step before actually requesting for parental karyotyping. So at the moment, it's the chromosomal analysis. It costs about almost 5,000 pesos, but we do have rates for our charity patients.
There's a follow-up. There's another question for you. Does the commercially available studies like 23andMe helpful in looking for genetic diseases, or are these tests not specific enough? Dr. Tan asked the question.
I think it's Dr. Timitan. Hello, Dr. Tan. The 23andMe was marketed maybe about 10 years ago in the US. It was available in Walmart or their other as a direct-to-consumer testing. But after some time, the US FDA actually stopped them from marketing the 23andMe test. No, so it's sequencing your whole genome, because the cost of sequencing has remarkably gone down by that time. Unfortunately, at some point, from the geneticist standpoint, as well as the genetic counselors, we look at it more as a recreational genetics. It does give you information about, it can give information about pharmacogenetics. So that's helpful for starting any medication. Second, it also tells you whether your genes tell you that your cerumen is wet or dry. And the other one is your ancestry. How much of your blood has, let's say, Caucasian type of blood or some other ethnic group. But now I think they kind of reinvented themselves. 23andMe is able to do some tests, useful tests for single gene disorders. So, but as I said, is it something that we recommend routinely to patients? No, especially also if it's provided as a direct consumer testing, because we do believe that genetic testing needs pre-genetic testing as well as post-genetic testing counseling. That's part of the standard of care for genetics. Yun lang po, Dr. Dindy. Thank you.
Thank you. The Northern American company.
Ma'am, sorry, Ma'am Dindy. The other thing that I wanted to say is that also the databases that they have, just like what I said in the presentation, it's heavily skewed to those of European descent. So there's not a good representation for the Asian, especially for the Filipino population. So it might not be a good test at the moment. Thank you.
Thank you, Doctor. There's a question for Dr. Iris. We'd like to know how they would join your master's in studies, Dr. Iris.
So we open our applications sometime, I think March, because the semester will start around September.
you just have to go to the UP Manila National Graduate Office for the Health Sciences, and you can see our brochure also online at the NGOHS. I'll try to put the link in the chat box. This is a 2-year program for a master's degree in health informatics. Thank you.
And you will announce that later at the chat box. Crystal, let me do that. There's a question for Dr. Calimag again regarding the HTA and looking forward with research. How does this affect the whole genomics and pharmacogenomics, the HTA Council? How do you look at this, being a member of that?
Actually, at the Health Technology Assessment Council, we IRIS is also part of that. No, we always look at the evidences to either accept or make use of certain technologies. No, and so, for example, for drugs, no, we always look at safety, efficacy of the drug, and then the cost. Sometimes there are some proponents. We know that for example, the drugs that they propose will be very beneficial to the Filipinos. Unfortunately, we have to do some price negotiations with the companies who are producing the drugs because it's very prohibitive, and therefore it will not result in equitable treatment options for Filipinos. So if you, for example, allocate a certain amount of money for a certain technology, you are actually depriving other Filipinos of that money to buy for something that will benefit more. So those are some of the issues that we're actually confronted with in the Health Technology Assessment Council.
Thank you, doctors. There's Dr. Iris has written and coded the link to the Manila National Graduate Office, Health Science. Another question is, what then is the genealogical test? I think this is for Dr. Eva. What then is the genealogical testing which is suitable for Asians and Filipinos?
There are a number of commercial testing. Well, one is 23andMe, and then of course there's Navigen. There are so many other companies, but somehow they kind of got lost somewhere and disappeared. Maybe because the uptake has not really been good, especially in our country. But if you're asking about good representation of the Asian population, I am not aware yet of any company that has a good representation of at least for the Filipino population. And that's why we really need to embark in this Filipino Genome Project, because not for commercial use, but mostly for our healthcare, for the healthcare system. The ones that Dr. Calimag also described in her talk, for pharmacogenetic studies, very important that we have a good reference database that truly represents the Filipino population.
Thank you, Dr. Eva. There were questions opened, stated by our former secretary, Dr. Dairy. I think Dr. Iris will comment on this. I'm putting on you on spot first, Dr. Iris.
So those 3 questions were really something that we need to think about, and I actually wrote them down. So there was one where he said, how will the technology affect the education of the next generation of health professions? And that's really something that all 3 of us are very interested in doing. So like we're looking at how can we incorporate in the curriculum, for example, telemedicine modules. We've done this over the course of the pandemic, but we're trying to make it more institutionalized. And I'm sure at the next APMC meeting for the medical schools, there will be a lot about the use of digital health for education.
That Dr. Calimag, I think you you have a comment on that. That's your.
We've been already trying to, of course, at the DOH, we had that NCBEG, National eHealth Capability Building Experts Group under Dr. Belisario, so that we can incorporate. In fact, I'm part of the technical committee on medical education that drafted and came up with the CMO, CHED Memorandum Order 18, series of 2016. And I made sure that incorporated into that document is information, the physician as information manager. No? Because with that and the NCBEG initiative of the DOH, no, to incorporate pharmacy informatics, medical technology informatics, or laboratory informatics, and then medical informatics into the medical curriculum. Definitely, I think we would have captured the whole spectrum of the need for to address the knowledge gap in information technology. And then, of course, address also digital literacy in the CPD. No, post-doctoral. Tapos na sila mag-doctor now, they are into the clinics. And then, of course, address that through the initiatives of the Philippine Iris, yung sa atin ni na Alvin. Digital
Philippine
health.
Society for Digital Health po.
Yes po. Philippine Society for Digital Health. So I think we're going full circle.
Forever.
Ma'am?
If you have something to say. If not, it's okay. I think they've expounded on this. There's another question. Because the academe is also with us. The proposals for the academe, on what level you propose that these researches, of course, compared to other countries, our research we're lacking so much researches. So before that, Dr. Ice is something you can read more about. Just a commercial break. You can read more about my work on medical education on my blog. She wrote it here. Thank you, Dr. Ice. But the medical education, of course, is there. But of course, the pre-medication, pre-med, even the grassroots level, and how low that, because we're now starting the, forgot the term, in high school. Before we only had grade 7, now we are now on grade 11.
8 to 12.
So we think that we have to 12. Yeah, we have to start our research there, or because even now the grade, the pre, not only the grade school, the preschool are learning all of this, and mind you, they're learning very fast. So let's go. How do you propose to bring it down to this level, the grassroots level of our having Philippine research? I think Dr. Calimag is passionate on this. Dr. Calimag.
Actually, we don't have so much problem with the young, no? Even 1, 2 years old, they speak English because during their language formation years at 2 years old, no? Hawak na nila yung cellphone eh. Hawak na nila yung YouTube Kids, no? They know the difference of many things, no? How to differentiate a whale from a shark, for example, by the orientation of the fins, no? So wala tayong problema sa young eh. I think more problem natin are the old, no? The digital literacy of the boomers, who are still, of course, very much with us, including ourselves. No? So, yung adoption ng digital yung how to become digitally literate, to go out of our comfort zones. embrace technology.
Thank you, Dr. Calimag. So, not all of us, as mentioned, are migrants of this digital technology. So we're getting there and looking forward to getting there. Doc, Ma'am Crystal, do you have something to say?
No, Doc Bibi, I'm just listening here.
Dr. Eva.
Yes, Ma'am Dindi, in response to your question. For example, at the Philippine Genome Center, we do genetics boot camps for high school students. And we allow the students to be exposed to genomics and bioinformatics. And they spend some time with us. This started way back before the pandemic time happened, but we are now continuing some of it online. So I think it's exposing them to what's out there, what other countries are doing in research, and how this can contribute to new knowledge for our country. We really have to start them at that stage. And also, there are many programs that the Department of Science, and a very important program that the Department of Science and Technology started is the Balik Scientist program. So we can have our Filipino scientists who are based abroad, who can come home and mentor young researchers, no, and help them with new discoveries. So I could see that there are many opportunities that are available, and of course the infrastructure. We're also building the infrastructure. We have a next generation sequencing facility at the Genome Center, which was put in good use during this pandemic, such that we are able to do our genomic biosurveillance and detect the variants coming in. And also we recently, the Genome Center also set up a proteomics laboratory. And to answer some questions about like looking at inclusiveness and equality throughout the 3 major island groups. The Department of Science and Technology also helped set up a facility in Visayas, a Philippine Genome Center in Visayas, and a facility and a Philippine Genome Center in Mindanao. So I think that is proof that we are trying our best to make sure that the regions will also have access to genomics technology.
Okay, thank you very much. I think we have all the time. There are more questions. I think we'll just email this to our very good speakers, and we'd like to thank all of them. Congratulate everybody, especially our speakers, our fellows in the fellows in public service, the Metrobank Foundation. Thank you very much for being with us. And for the questions, we will be answering this online. We will email this to you. I will now go back to Miss Crystal. Miss Crystal,
Thank you, Dr. Dindi, and salute to our 3 new Metrobank Foundation Fellows in Public Service. So unfortunately, our actors are not able to join us this afternoon. But anyway, we do have a certificate for them. So thanking them for being invaluable resource speakers and reactors this afternoon. So thank you also, Dr. Dindi Hugar, for facilitating our open forum. The discussion really has been insightful, and you have asked your questions. So thank you very much for that. Now, to give the closing statement, we have Manila Doctors Hospital Medical Director, Dr. Mario Joselito Cuco, and just after his talk, may I just request our speakers to stay until we have our souvenir photo opportunity after the message. So Dr. Huko.
Thank you. Am I clear, loud and clear?
Yes, sir, you are.
Okay, thank you. Mr. Aniceto Sobrepeña, President and the Board of Directors of Metrobank Foundation, Incorporated. Mr. Nick Torres, Executive Director. to our three distinguished Metrobank Foundation Fellows in Public Service and outstanding Filipinos, colleagues in Manila Doctors Hospital and in the medical profession, and other esteemed guests, good afternoon. I would like to congratulate and thank our three speakers, Metrobank Foundation Fellows in Public Service and outstanding Filipino awardees, Dr. Iris, Dr. Eva, and Dr. Irvi, on your conferment and for your excellent presentations. I would also like to thank our reactors as well, Dr. Manuel Dairit and Dr. Jimmy or Jaime Montoya. As we continue to live in a COVID-19 pandemic-filled environment, we are learning to see the world in a new light and with new eyes. Today's event is a milestone as we have been truly blessed with the opportunity to hear and learn from the experts sharing their accomplishments and best practices in the fields of medicine, research, science, and technology. Today's proceedings will serve as a guide in our practice as we take care of the health and well-being of our patients and their families so they can live longer and live healthier. We would also like to thank the Metrobank Foundation for launching the Fellowship in Public Service, or FPS, as we now have the venue and opportunity to hear and learn from the experts who have been recognized for outstanding work and exemplary dedication and service to the country. The FPS program is only one among many of the Metrobank Foundation. To date, Metrobank Foundation has paid tribute to 685 outstanding Filipinos who have made a difference and brought about positive change in their respective communities. In closing, on behalf of Manila Doctors Hospital, the healthcare arm of Metrobank Foundation, Metrobank Group, let me again express our sincerest gratitude to Dr. Eva, Dr. Iris, and Dr. Irvi for sharing with us their time and expertise. I would also like to extend our appreciation to all participants and your respective organizations and institutions for taking time out from your busy schedules and duties to join us on this fellowship in public service conversations. Until the next FPS Conversations event, thank you everyone, and please stay always safe. Magandang hapon sa inyo lahat.
Thank you very much, Dr. Hugo. For our participants, again, don't forget to answer the feedback form. Certificates of participation will be provided to those who will be answering the evaluation form. Now, today, before we end, may I just say that we are pleased to launch the 2021 Metrobank Foundation Outstanding Filipinos Souvenir Program. The publication chronicles the awardees' narratives of triumph and resilience. Featured here are also two of our awardees today, who spoke with us today, who are with us today, so sorry. Dr. Thiele Isip-Tan and Dr. Maria Minerva Calimag. Please look this up and download. These stories are very inspiring, and they do remind us that all of our actions, whether big or small, will bear lasting transformation as long as it is done for the right reasons. So click on the link posted on the chat box to download your copy. All right, so this concludes our program for today. For more updates about the Metrobank Foundation, Fellows in Public Service, and other programs, visit our website at mbfoundation.org.ph. Also, follow us on Facebook and Instagram at Metrobank Foundation and on Twitter at Metrobank Found. So it has been my privilege to serve as your host. Thank you and stay safe. May there be a better future for all of us. For our panelists this afternoon,